Hey everyone, how's it going? Thank you for joining me this very early Tuesday morning. I do appreciate it. If anyone's having trouble sleeping and they'd like to go back to bed, just leave me on in the background and be able to get most of it. As most. Actually, wow, you guys have like a really good schedule this week. My gosh. Look at that. Nothing after me in Kaplan today, and then no 2:30 to 4:30 blocks. Hey, Kate. Hopefully the Oscar went well. Hey, Kyle. Kicking off here in just a few moments. Hey, Cassette. Kelly. Thank you all for joining me. LB. Right. I'm just trying to acknowledge everyone who's being interactive. That way I can get you guys to come back. Future. Jackson, going. Nelson Rubasha. All right. Our usual crew, about 20 or so. That'd be good. And of course, if you have any questions, go ahead and pop them up in the chat here or the sticky board. Either are fine. We're going to continue on. I think we're talking about risk. That's the last thing we stopped with. All right. Well, it is 8 o'clock, so let's go ahead and get kicking off here. So, last time we were talking about risk, and risk is a pretty simple sort of calculation, right? You just take the number of people that a thing happened in, and you divide it by the total number of people at risk. So, if you have like a year-long period, you have 100 people, 10 of them died. That's a 10% risk of death over that year, right? However, you will find that there are some limitations with that. And so it has to do with like when do those people die? Do they all die at the same time? Is it like a steady instance of death throughout the year? Is it all at the end? And so that's where this concept of rate is really going to become helpful for us. And so again, I hate to make this so dour of a topic, this early in the morning. But death is a pretty good thing to use for these talks because again, it's a yes or no sort of definitive sort of thing there, right? But looking at this, let's assume we have 3 different nursing homes and they all have roughly the similar patients of, same population size, same age distribution, all of that. And so we find that they have these 3 different nursing homes, and they don't have any new people being admitted, no people leaving other than death. Let's say they all have the same overall risk of death. They're at a year-long period. 10 of them out of, say, 100 all die, or at least 10%. And so we're going to see that actually the patterns of death can be very different between them. And so if you go on to the next slide here, you can say, let's sort of go with this hypothetical that population A, let's say they had like a really bad influenza outbreak during January. And so the majority of those people that were going to die, that 10%, all died the very first month in January. We'll find that B didn't really have any sort of epidemics hit throughout that time frame. They all just kind of had a very steady death throughout the year. And then with C, they actually had all of it happen like in December, right? All the deaths, most of them occurred in December there. And so like how do, if you look at risk, it's all 10% here. So how do we really differentiate between these? And this is something called a force of mortality to see like, okay, was this happening at the beginning? Was it steady throughout, or is it at the end there? And so by using rate, that's going to be able to help us out and be able to distinguish between those and be a little more precise. And so if we were to look at this, you can look to see this is January 1 all the way to December 31st here. You can see in the blue, this is where the people that actually survived throughout the year, and then the white portion being people who were not alive towards the end. You can see here, 100% of people alive at the top and then 0% at the bottom. So looking at this, we can see the three different populations here, sort of what happened. And I misspoke on that last one. It was actually B who had the epidemic in December, and then C was the one that was steady throughout the year. Apologize. Anyway, but this makes sense here if you look at it. So with A, you can see here that the majority of people died off in the very beginning, and then it was sort of steady down to that 90% at the end. With C, it was very steady throughout the entire time. And then with B, very few deaths early on, and then they all kind of just dropped off at the end there. And so rates can be really helpful to be able to differentiate between these sort of three patterns of death that happen in this group, right? And so basically rate is the frequency of events that have occurred in a defined time period, so a year in this case here, divided by the average number of people at risk during the study period, okay? So that's the difference here, is that with risk, it's the total number of people at risk for an event happening in the denominator, but here we're going to find that the average number of people at risk is going to be used as our denominator. So how do you figure out what the average number of people at risk was? Well, this is where we use the mid-period population there, right? This is a good estimate of roughly the average number of people at risk for an outcome actually occurring there. And so instead of using the total number of people, we use the midpoint population, okay, or the mid-period population here. And so you could look at it like this, as the numerator being the total number of events, denominator being the mid-period population, and then usually we'll have some sort of constant multiplier. And I'll talk about that here in just a moment, but you see rate is going to be the ultimately what we're getting. So you'll typically find that risk and rates generally are going to be less than 1, right? Because it's usually a percentage of the whole, unless it's something that happens like more than once. So if you had something like, people can get an asthma attack more than one time in a year, for instance, or something like that. If it's something like death, where it's either happened or it didn't, then it's generally going to be less than 1 here. And so as I mentioned last slide, rates are usually multiplied by constant multiplier. This just makes it easier for people to be able to talk about the numbers, and makes it more relatable to general people, right? If you're just talking to like a lay person, for instance here. And so looking at this, if you multiply it by 100, then it would be a percentage. So for instance, instead of saying, okay, well, 0.1, of the population died here, you just say you multiply by 100, so that way it's 10%, right? Makes it a little bit easier. 10% people can usually kind of understand. And then typically, especially if the rate or the risk is like really low, it's like it's a fraction of a percentage, then you're going to find here that we may multiply by 1,000, 10,000, or 100,000, something like that. It makes it easier to discuss. So that way you can say, oh, there's 1 death per 1,000 people per year, for instance, instead of saying 0.001 of the population or something like that died. And then you're going to see that when we use a constant multiplier, you have to multiply both the numerator and the denominator by that same number, so that way the ratio doesn't actually change. This way everything stays the same in terms of the ratio, but that just makes the number bigger for us to understand. I'll show you some more examples of that in the future. So looking at this, looking at crude death rates, I can illustrate this, right? Here's the example. So let's say in 2003, the rate for death in the U.S. was 0.0086 per year. That means out of the whole population of the U.S., 0.0086 people per year died. But that doesn't really make a whole lot of sense when you express that. However, it could be easier if you were to say, okay, let's multiply both numerator and denominator by 1,000. And we can say, well, there are 8.6 deaths per 1,000 individuals in the population per year. And so that makes it a little bit easier. You could have also done like 10,000 here and say 86 deaths per 10,000 people per year. And again, it just helps to put things in a little bit better perspective for when you're talking about it with lay people, right? If you're talking about like what's the risk of death, to your patient when they're going back to surgery, you can say, well, this many deaths happen in 1,000 people or 1,000,000 people, or whatever the case may be, and that makes it just easier for them to wrap their heads around. So going back to looking at the relationship between risk and rate, you're going to see here that again, with populations A, B, and C in our nursing home example, they're all similar in size, and they all had, again, a 10% overall risk of death. But as we were mentioning, that the patterns differ quite greatly. So looking at, A died off very early, B died off very late, and then C was just kind of steady throughout. And so again, we can kind of make some look at how the rates will actually differ as opposed to the risk being 10% in all of them, right? So looking at this, and again, have the picture here just for your reference, looking at population A, because most of the deaths occurred before July 1, you would see that their mid-period population is actually like the lowest out of the bunch here, right? And so their denominator would be the smallest, which would make that ratio the largest out of the bunch here, right? And so even though the numerator is still the same size, still 10% of whatever the total population is, you're going to see that their denominator will be the smallest out of the bunch. Whereas with B, you're going to see it actually has the lowest risk because their denominator is the highest, because their mid-period population was the highest in July 1, even though, again, the risk is all the same between these three here. You see most of these people died off at the end. And then C is going to be somewhere in the middle there because, again, they had a very steady death rate. And so you can see in July 1, they had sort of the in the middle mid-period population here. And so you can actually calculate out what the different rates would be, and you'd see that A would have the highest rate, whereas B would have the smallest rate because the denominators are different there. If that doesn't make sense, let me know. And so, as I mentioned, rate can be sometimes used as an estimation of risk, and you'll see that it's a pretty good estimation. Again, if you don't know the total number of people at risk for a population here, but rate can be a useful substitute because they're generally pretty simple if these conditions are met here. So, for instance, if the event in the numerator only happens once per individual during a study period, so again, if you only have people that can die once, as opposed to maybe have maybe some undead individuals, actually. I just heard a story about a zombie deadlifter who pulled his back. I'm sorry, he's a zombie bodybuilder, but he had pulled his back out when he was deadlifting. I apologize, very early in the morning, so jokes aren't rolling off the tongue quite right. Anywho, but you can see here if the event only happens once, that's going to be helpful there for helping for rate to be approximation of risk there, and if it's a relatively small proportion of the population being affected, so generally less than 5% or so. And then if the time interval is going to be relatively short there. Yeah, so we're going to say that population B here would have the lowest rate because their denominator would actually be the biggest. So because their denominator is the biggest, that makes that ratio the smallest out of the bunch there. But A would have the highest rate, C would be in the middle, and B would have the lowest rate, versus risk being the same between all three, okay? So it makes that distinction there between rate and risk because the denominators are going to be different. Okay. So when you're looking at this, if you look at the time interval, if it's like really, really long, or if you look at the percentage of people who meet the condition, so for instance, if it's like, 20% risk or something like that, then you're going to find the rate actually is much larger than the risk because, again, that mid-period population changes quite a bit if you're looking over a long period of time or if there's a big drop-off in the number of patients there. So just something to know if you're kind of trying to compare the two there. If you're wondering why they're different, that's why. So we're looking at this. So valid rates have to meet these conditions in order for it to be valid, right? So it has to I'm going under these assumptions here. So all the events in the numerator must have happened to people in the denominator. So that way you're not counting people outside of that population, right? And then all people counted in the denominator have to have been at risk for the events in the numerator, right? So if you're looking at, for instance, like cervical cancer, you don't want to count that in people. You don't want people in your denominator who don't have a cervix to have gotten the cancer in the first place, right? So definitions are really important here, making sure the right people are being counted in both the numerator and the denominator here, right? And so when you're doing rate comparisons, you're going to see that the numerators for all groups must be defined and diagnosed in the same way. This is a challenge, especially when you're looking at rates between like different countries, for instance, if they have different means of defining things or diagnosing things. And so we'll talk about some of those challenges coming up here. We also want to make sure the constant multipliers are being used are the same. So if they're using like per 10,000 individuals or per 100,000 individuals, that all has to be the same there. And the time interval should be similar. Okay. So you may find that the numerators, as I said, may not be easy to compare if you find that the quality of the diagnosis actually changes over time. So this is a good example of trying to compare between two different time periods. So if you went back to the late 1800s, for instance, we didn't really have an idea of what myocardial infarction was. We just didn't really have the means to diagnose that. But you have a lot of people who are dying of acute indigestion. You wake up and like, oh, got this terrible GERD, and then you drop over dead, right? Well, nowadays we know that no one really dies of acute indigestion. It's mainly due to MI, right? So by the time you got to the 1930s, for instance, it was actually reversed there. And now you couldn't look at rates of myocardial infarction in the 1930s and then compare that to the late 1800s because they really wouldn't be valid there because back then no one was really getting diagnosed with that, right? So, and it's impossible to go back in time to figure out which ones were actually MI and which ones are actually due to something like, acute indigestion. Maybe it was a peptic ulcer or something. But again, another thing we can look at here is called incidence rate. So again, this will be the number of new incident cases over a defined study period divided by that mid-period population there, right? We talked about incidence as being new cases of something happening over a time period. You can also use incidence rate, but it's just your denominator is going to be what's defining that as a rate using the mid-period population. And then again, that constant multiplier is frequently used here. Again, we mention this because, you'll be reading studies and they'll be using these terms here. And that's why I want to make sure you understand kind of what the differences between these things are. So that way you can make correct evaluations and interpretations of the data there. Okay. So there's another term here also that's important, especially for events that can happen potentially like multiple times. And this is called incidence density. So it's kind of an interesting one where it's referring to the frequency or the density of a new event per person time. And so this is something you may see where they'll talk about it. Oh, we had this many cases per person months or per person years. And so you can look at that. So say, for instance, we're looking at patients, 3 patients, and they all had tonsillectomies. And then we're looking to see how many recurrent ear infections they got afterwards, right? And so you followed patient 1 for 13 months, you followed patient 2 for 20 months, and then patient 3 for 17 months. And then if you counted all the number of ear infections that happened here, they got a total of 5 between all 3 patients here. So basically, in order to get an incident density, what you can just do is look at the total number of incident cases divided by the total amount of time that you follow these individuals here. So this totals up to be a total of 50 months that you follow these individuals here. And so you can say incident density is 5 infections per 50 person months. Or you could talk about it in terms of making it a little bit more of a round number and say, okay, well, there would have been 10 infections per 100 person months, right? So you can kind of slice and dice that a few different ways. If you were, say, trying to apply this back to your patient, you could say, well, if we followed you for 100 months here, which again, you probably wouldn't be doing, but if you did, we would expect you to have about 10 infections, 10 ear infections, based off the data here. Or, for instance, if you wanted to follow 10 people for 10 months apiece, then maybe each one of them in total, if you had total all of them up, would have 10 ear infections. So maybe 1 per person, essentially. So there's a couple of different ways you can kind of analyze that based on how you want to talk about it. If you want to talk about multiple people or just 1 person, that's how you would do it. And so this is really useful using incident density if it's something that can happen multiple times. So like MI, otitis media, anything, infection, anything like that would be perfectly reasonable there, okay? So when we're using risk and rates here, they're typically done to make comparisons, right? If you want to compare different populations together, we do this quite a bit where we're comparing ourselves in terms of like the US versus other countries to see how healthy we are in certain degrees or certain respects. We can do lots of different compare 2 different populations within the US, for instance, a lot of things like that. So for instance, if we're looking at the US national health goals in 2010, for instance here, you would, they include all kinds of expected rates, right? So they say, well, this is what we're going to be shooting for there. Let's say we want an infant mortality rate of X, and then you can then compare that to what actually happened and see what the difference is. Were we healthier? Were we less healthy than that? And so that can be very useful there. And again, you can do that with different countries. You can do that with different time periods, as long as everything is being done equally in terms of like diagnosis and things like that. So, as I mentioned, you can compare two different populations at the same time. This is probably the most common one here, right? So if I'm comparing death rates or disease, for instance, in different countries, you could look at different states. You could look at different ethnic groups for the same year period. So for instance, you could look at like COVID death rates between the US and different countries, like in Europe, for instance. Or if you wanted to do like a randomized controlled trial, you could look at risk and rate comparisons between treatment and control groups. That's kind of what we've been classically thinking about when we've been going through like the biostatistics portion of the class there. That's kind of what the examples would be that I brought up most often there. And then you can do different time periods, as I mentioned. So this is good for looking at trends over a period of time. Again, this can be difficult depending how different the time periods are actually going to be there. But if you wanted to look at things like, what's the proportion of elderly individuals in the U.S., you can look to see how that's changed over time. We can look at things like disease rate differences over time, things like that. That can be pretty useful to see like, okay, what kind of trend are we seeing here? Are we getting better? Are we getting worse? Things like that. Again, though, remember that over time, the diagnostic capabilities typically change, so making rate comparisons of now versus, say, like 1900 would be challenging. You got to make sure the data is good enough to make the comparison in the first place. So, looking at ways to make these comparisons, it's important to make sure you're doing apples to apples and not apples to, I don't know, kiwis or something. And so we're going to talk about 3 different types of rates you can run into. And so these are pretty broad categories here, but I'll talk about how we calculate these. There's crude rates, there's specific rates, and then standardized rates. And they all have sort of their uses here, as we're going to see. They're all done a little bit differently. And so again, on the test, I'm not going to have you specifically calculate out a standardized rate or something like that, but I do want you to know what they're used for, kind of what the purpose of these are. And so when we're looking at rates that apply to an entire population, if we're not going to be comparing or controlling for things like age or gender, ethnicity, or anything like that, if we're just looking at the raw numbers, we call that to be a crude rate, right? It's crude because we haven't done anything to it. It's the least sophisticated out of the 3 here, right? If we then if we try to divvy up the population based on particular characteristics, right? If you wanted to look at things like risk factors, smokers versus non-smokers, break things up based on race, sex, etc., then we can call those specific rates, right? So you'd have like an age-specific rate or a sex-specific rate, whatever the case may be. Again, a little more sophisticated because now we're not just using a big lump number. Now we're looking at more specific groups here, which is why it's a specific rate. We'll talk about standardized rates and how they are useful in just a little bit, though. So, as I mentioned, crude rates are valid, but they can be a little bit misleading here. So let's look at an example where we have 3 different countries. And so the information is a little bit old, but the point still stands here. But let's say we're looking at Sweden, we're looking at Ecuador, and then the US. And we want to see which one has the highest and lowest crude death rates out of 2004. I'll show you the numbers here in just a minute, but basically what you found is that Ecuador had the lowest crude death rate, Sweden had the highest, which would seem a little bit counterintuitive. Like if you're thinking about, the wealth or health of a nation, you might think that Sweden might be a little bit higher, Ecuador might be a little bit lower here. But if you look at the crude numbers, it looks like, yeah, Ecuador's got the lowest crude death rate. So, maybe if you want to live longer, move to Ecuador. Well, it's not quite so specific or not as clear cut as that because these are just using crude numbers here. However, if you were to look at the age-specific mortality rates, and also if you're looking at life expectancy, it actually is going to be reversed here, where Ecuador has the highest age-specific mortality and the shortest life expectancy. Sweden's going to have the opposite of that. And again, you're going to find that the crude rates don't take into account the difference in the population in terms of age, right? So which one has an older population versus which one has a younger population. And so if you look here, Ecuador has a younger age distribution, right? The median age is 23 in Ecuador, at least at this time frame. And so the other thing you're going to see with that is that the crude birth rate is also likely to be relatively high. If you have a larger, younger population, they're probably reproducing more as opposed to an older population. And it's also because more of the people are skewed younger. This makes their crude death rate also relatively lower, okay? Unless there's something really bad going on, like horrible outbreak or disease or something like that. But Sweden, being an older population, you're going to see they have lower crude birth rates because more people are starting aging out of childbearing potential, and they also have a higher crude death rate because if their population's older, then more of them are closer to death, and they're just dying off, right? And so you find that age has this really profound influence on that force of mortality, right? They have a huge influence on those actual crude rates there, which is why we need to look at age-specific rates. That's how you take into account the differences in age amongst a population. If they're skewing younger or older, we can control for that. Again, even if you have an older population, even if it's relatively healthy, they'll still have a higher overall death rate than if you go to a country with a higher age-specific death rate, but a younger population, right? So it can really have a big influence there. And just to show you the example here, if you look at the crude death rate of Ecuador, the U.S. versus Sweden, you can see that it looks like Sweden has the highest death rate, but it doesn't really comport with the idea that they have the older population. It's like, well, they have a higher crude death rate, but people are living for longer. It doesn't really make a whole lot of sense there until you look at the age-specific rates, okay? All right. So, and again, because of the fact that, age has this really a big biasing effect that we can see there, we can control for that, right? You can break up age groups into different categories, right? So you can look at the 1 to 18-year-olds, you can look at the 19 to 30-year-old, you can break these down. And so what we call that is going to be age-specific death rates. And that allows us to be able to make fair comparisons between different age groups in a country there. And so this is how we calculate that. And again, it's the same exact formula we saw before. It's just the number of deaths in a particular age group. If you want to look at 60 to 80-year-olds, for instance, divided by the mid-period population. So we know this is a rate, and again, multiplied by whatever our factor is, times 1,000, a million, whatever you want to make it, okay? And so the crude death rate, actually, if you just took all of your age-specific death rates, all those slices of the pie that you made for the different age categories, and added them all up together, you'd still get basically the crude death rate there, right? The crude is just the total lump sum of all the deaths that occurred. The age-specific death rates are the ones where you kind of divvy them up there. So obviously, if you add them all together, it should just get the crude rate. And so when you're looking at this, if you're, say, comparing two different populations, you have to compare the relative weights or the size of the various age population, the various age groups you're comparing there. And so by looking at the differences in the age-specific death rate, you're able to make a better fair comparison between the two there, right? A more fair comparison than you could make with just using crude death rates. So we're going to see, for instance, too, like a similar problem also can happen, and for instance, in hospitals. If you were to look at a death rate of a hospital, obviously you want to go to the best hospital you can if you're sick or if your parents are sick or something like that. And so, I want to go to the hospital with the lowest crude death rate possible. And that may not really be a good estimation there, right? So we have to take into account adjustments for things like, well, what type of illnesses are we seeing there? What type of severity of disease are we seeing there? Otherwise, you're going to find that the hospitals that take care of the sickest patients are going to be sort of at an unfair disadvantage, right? So I always use this example here. In Orlando, we have several children's hospitals, but let's compare something like Arnold Palmer Children's Hospital. Like, let's look at their NICU, the neonatal intensive care unit, versus something like Nemours neonatal intensive care unit. If you were to look at the actual death rates between the two there, it would probably look like Nemours is higher. I don't know the specific numbers, but if I had to guess. And the reason for that is because, well, if you go to Arnold Palmer, they're actually birthing children there, right? They actually have people being born there, and a lot of them tend to be healthy, right? Versus at Nemours, we don't have anyone being born there. Or if they are starting to be born, we ship them off to another facility because we don't take care of the moms, right? We just take care of the kids. And so also consider this as well, is that one, Arnold Palmer has more healthy kids being born there, but also we get a lot of really sick kids being transferred to our NICU. So if you are at an outlying hospital, if you have a NICU patient showing up at an adult facility because that's the only one around you because you're in the middle of the sticks, then they would then get transferred to us. So we get a lot of sick kids being transferred to us, on top of the fact we also don't have healthy ones being born there, and thus you would look like it has a worse death rate, right? So you have to take into account things like severity of illness, the type of patients you're seeing and things like that in order to make fair comparisons, okay? So crude numbers can be misleading. So one way we can help to, again, make a more fair comparison is use something called standardized rates, right? Or otherwise you may see these called adjusted rates here. And these are ways we can sort of modify the crude rates in order to control for different things like age, for instance, or other characteristics in order to make fair comparisons between two groups there, right? And so one way we can do this is to obtain, summary of death data, and get a series of age-adjusted rates, and then now make comparisons here. And again, you can use standardization processes to do this for any type of rate, right? It doesn't have to be death, but this is the example that we're going to be using here. So, there's a couple of different ways to do it. Talk about direct standardization probably being the most common method here. And again, it helps to remove biasing effects of things like age, or it could remove biasing effects of different things like gender, race, etc. And so in this direct method here, what we're going to use are age-specific death rates of two or more populations, and then we compare that to a single standard population, right? So it's saying, okay, well, if we took the age-specific death rates for this population, what if we applied it to a very standard sort of population? I'll give you an example of this in a moment here. What would it look like? And then you can then make a fair comparison between the two groups there. And so basically this is done by multiplying each of the age-specific death rates to sort of this hypothetical sort of standard population to see what it looks like. So this chart looks terrible, I agree, but kind of stick with me here for a second. Let's say we were looking at two different populations. We have population A and then we have population B. And this part here is just looking at their accrued death rates, right? You can see the age groups here, so young, middle-aged, and older. That's how they decided to divvy up the different populations here. And if you look here, population size, you can see that how it's sort of skewed. So if you notice here with population A, they have a much older population, versus in population B, they have a much younger population, right? See how it skews differently here? Now, if you were just to look at the crude numbers here, the crude death rate, they had 451 deaths out of 10,000, which it means 4.51% of death in population A, and they only had 308 out of 10,000, or 3.81% in population B, right? So it looks like if you just looked at the crude numbers, oh, well, population A has a higher crude death rate, they must be less healthy, right? Well, what if we took these specific numbers here, these age-specific death rates, and then we were then to compare that to sort of an idealized population that is the same, right? So if you then look at this and compare down here to this fictitious population, notice here now it's even 5,000, 10,000, and 5,000 with the age cohorts versus here 5,000, 10,000, 5,000. Look, notice how the populations are the same here, but the age-specific death rates are retained, okay? So you notice here this is just carried down. This here is carried down here. And so what you notice is now that we have this idealized sort of hypothetical population, what would happen here? And so then if you look at it, well, if you had this, you'd get 605 out of 20,000, or 3.03% of the population died, versus 1,210, or 6.05%. Right, so this is, by looking at this, we can now make a fair comparison between the two here and say, well, yeah, it looks like the actual death rate when you account for age is twice as high in population B. And you can investigate why that is. Is it less healthy? What's going on here? So this is a direct standardization method to compare two different populations together. So let's look at some common maternal and infant health sort of statistics here, because these are things you might be reading about, especially if you go and doing OB-GYN stuff, or if you're looking at general health of populations and things like that, because it's a little bit dour to talk about, infant mortality and things like that. I decided to include two cute pictures of my kids. This is Lily here on the left and then Phoebe on the right. I don't like to typically show my kids off in social media and things like that, but I figure at least one picture is probably not going to hurt anyone. These are fairly recent. So and Phoebe's started knocking on my door whenever she wants to come in, so she might start doing that. It's her new habit now when I'm recording. But so let's talk about some of these common rates that are talking about maternal and infant health, because this is something that is frequently used to talk about general health of a nation, right? If you have a healthy nation, typically pregnant women are living through childbirth, and you have infants that are living through the first year of life, okay? That's a general concept. And so we can use things like infant mortality rate to give us an idea of how healthy a nation is, and then, again, use those comparisons. And so here we're going to call a live birth is basically the delivery of a product of conception. And again, it's a very clinical term, as you can see here, but they're showing any sign of life after removal from the mother. So it could be a breath, could be a cry, anything like that is considered to be a sign of life. That's considered to be a live birth, right? And so looking at this, you can slice and dice this information a lot of different ways depending on how you want to look at it. So for instance, and they can tell you different things, right? So I'll show you some examples of that. But fetal deaths, we can kind of consider this to be either early, intermediate, or late fetal deaths here. And a lot of it has to do with the gestational period, right? So for instance, if you have an early fetal death, usually known as like a miscarriage, this is happening when basically the death of the fetus happens within the first 20 weeks, right? And again, by looking at the different time periods, this can give you an idea of like, okay, what was happening here? Was this an issue of like early fetal demise? Was it more of a late sort of thing where it was after 28 weeks of gestation? They can tell you a few different things there, right? So for instance, if you had like a drug exposure that was teratogenic, causing fetal demise because organogenesis was screwed up, this could be something you would recognize in the early fetal deaths, for instance, right? So you have the early, middle, and intermediate or late sort of fetal deaths here, and then talking about infant death is anyone that's kind of live born, right? So they actually were delivered from the mother here, and so we call an infant death anything that happens when that first birthday, or before the first birthday. Really, an infant is that talking about that first year of life. That's kind of the general definition there. Whereas with like a neonatal death is anything within the first 28 days. That's when you call them still a neonate or a newborn, is during that 28 day period. Infant, whole first year. Neonate's going to be the first 28 days. And then you can even further delineate that if you can look at post-neonatal death, right? So again, these can tell you something. So for instance, if it's a neonatal death, maybe it has to do with something with the actual delivery itself. Maybe there was some kind of complication there. Versus a post-neonatal death is probably due to something happening at the home, for instance. Like, was it a case of SIDS? Was there a drowning? What's going on at the home that has led to this death, as opposed to something that was more early on, maybe related to the actual delivery, right? And again, the rates are calculated exactly the same here. So if you wanted to look at crude birth rate, which again is telling you basically how often the population is reproducing here, you're just looking at the number of live births divided by the mid-period population, the people who were at risk for giving birth, essentially. You may look at like pregnant patients, for instance. And again, multiplied by whatever constant multiplier you want to use there. 1,000 is one used here. So again, looking at health of the infants, it's usually pretty sensitive to things like maternal health practices. So was the mom utilizing illicit substances? Was she exposed to environmental factors that could affect it? How good were the health services that she had access to, right? So things like infant mortality rate, basically, as I mentioned, is kind of an overall index of the health status of the nation. It's one that's commonly used to make comparisons between different countries, for instance. And again, you're going to find the infant mortality rate is useful because a lot of people have access to that information. Usually, birth rates are going to be pretty well documented in a lot of cases there. Of course, there's some caveats to that, like home births and things like that. Not everyone gets counted, but the majority of people do. It's usually pretty well collected. And so again, we can find things like the numerator and denominator for infant mortality rates can be obtained from like vital statistics reporting, so like the census and things like that can be very useful for getting that sort of information there. So if you want to get like infant mortality rate, then you would look at the number of kids that died less than 1 year of age divided by the number of live births. And again, this can tell you, for instance, infant mortality rate like from hospital to hospital, right? You could look at it from state to state. It just depends on what time, place, or what time period and place you're actually looking at, or you're going to be using here. So looking at pregnancy specifically, you can look at maternal mortality rate, can also give you good information as well, because of the fact that pregnancy, while a normal condition, is still very stressful for the mother from a physiologic standpoint. You can have hemorrhage, you can have infection, all kinds of problems that can develop from this. But again, how well are we taking care of these moms? So if we have a low maternal mortality rate, that generally means that they had better access to care. It means that they also are, dealing with complications from other conditions like, how are we managing their heart disease while they're pregnant, their diabetes, etc. And so by looking at mortality rate for the moms, that can give us an idea of how well we're taking care of them. Do they have access to adequate nutrition? Were they being seen by a provider regularly throughout the pregnancy? All that good stuff. Notice here that they're using the number of pregnancy-related deaths, but the denominator, is actually the number of live births, because, again, it's assumed that if a child was born, they probably had a mom that they were born from, and so that's where they actually use that number there. So it's calculated a little bit differently, but still you get the idea. And again, as I mentioned, related on, or numbers based on the pregnancy-related or puerperal deaths here, because again, death of a pregnant woman or one who's recently delivered, usually not going to be considered, or when we're looking at those numbers, we're typically not considering things like, for instance, if you died from a car accident, right? That really doesn't have anything to do with how we took care of the mom throughout the pregnancy, or if they were murdered or something like that. So again, how you define those numbers is going to be really important here too. And so as I mentioned, we use the number of live births because again, they had to come from somewhere. So it's probably from a pregnant mother. So that's kind of a quick and dirty sort of rundown of rates. So kind of understand what a rate is, how we use them, understand the difference between like standardized rates versus specific rates versus crude rates. You should have a good handle on that kind of stuff for the test and when you're evaluating the literature. Let us continue on. I'm going to open up the next one here. So number 13. I didn't want to do that, right? I don't see any questions up on the sticky board, so I'm just going to go ahead and continue on here. So let's talk about epidemiologic surveillance and outbreak investigation. So this is something kind of near and dear to me a little bit because this is sort of what we did, part of what we did at the Poison Center itself. We did a lot of surveillance for disease. I've talked about a little bit of that in the past where things like, new onset of disease due to, say, like a new illicit substance that's on the streets, right? It's like when bath salts first came out, or when we had Deepwater Horizon, the big oil spill in the Gulf. We were tracking disease and using good surveillance through people calling the Poison Center, because a lot of times if people think that they've been exposed to something that's making them sick, they call the Poison Center, or at least that's one route. And so it's a good way we can collect data on that sort of thing there. So what is surveillance? Well, it's how we're collecting, analyzing, and then interpreting data. And then how do we then report it out, right? How do you inform people to let them know about new incidences of death or disease and prevalence of conditions, and especially how they change over time? We think about surveillance in the U.S. here. We think about the CDC as being one of the major ones here, right? They're responsible for most of surveillance of like acute diseases. They look at outbreaks and things like that. Typically, if it's on like just a statewide level, so if there was like, for instance, a rash of hepatitis A outbreaks, like there was a couple years ago here in Florida, if it's just one state being affected, the CDC doesn't necessarily get involved unless they're requested. Usually the Department of Health are going to be the main people taking care of that. And they have a whole host of epidemiologists that work for them that can do these investigations. If it's something that is going to be interstate, so it's affecting multiple states, then the CDC automatically kind of comes in and they start to do their investigations. And so again, they're looking at different sources of data to look for these blips on the radar, so to speak, to clue them in that something's going on. They need to do some further investigations there, right? Again, CDC is very helpful because they can help to augment and facilitate the state investigations that may be already going on in the first place here. So we're going to look at how they actually go and do these sorts of things here. Like how do they, define what an epidemic is? Like how do they actually go through and come up with like, how do they investigate this stuff? This is what we want to know here. And so, again, as I mentioned, the CDC is going to be typically a first responder if there is sort of an interstate sort of implications here. Otherwise, it'll be state governments are doing the intrastate, right? So, for instance, if it was something like coronavirus first coming over into the U.S., if it was like in New York, for instance, and probably New York State Health Department that was mainly managing that, but because it had kind of worldwide implications, CDC probably stepped in pretty early there as well to start to look at that sort of thing, right? So sometimes they're a first responder, but it just depends on kind of how it's going. But let's say we wanted to create a surveillance system. How would we go about doing that? And so this is kind of what I want to get into during this lecture here. And so you can do surveillance systems for all kinds of things, right? You could do it for infectious diseases. You could do it for if you're introducing a new vaccine into the market, you could look for side effects. There's something called VAERS, which is the Vaccine Adverse Event Reporting System. Anytime you ever get a vaccine, you probably get information about VAERS, because if you have an adverse effect like Guillain-Barré or something, you can call them and report that, right? Or use a provider maybe reporting it. But you can look at anything, right? Poisonings obviously is going to be my my sort of surveillance du jour, because that's what I specialize in, right? So right off the bat, you have to make sure that your expectations are pretty clear, your objectives are clear for doing the surveillance, right? So if you're looking for cases of chickenpox, You need to know why you're looking for that. Well, we want to see if the varicella vaccine is effective here, right? We want to see, like I mentioned, if we're going to have a COVID vaccine coming out in the next couple of months here, we sure as heck better have a good surveillance system in place to make sure there's not going to be any adverse effects that are happening. Because again, when you introduce things into millions and millions of people, or billions, depending on the situation, that's when you're going to find these small incident or very low occurrence sort of events, and you want to be able to document that, right? But you could do this for really anything you want to do surveillance on. So then we have to have criteria for defining what our case is actually going to be. Like, how do you actually define what a particular case? Like, how do you define who a person is going to be counted in the surveillance is? And it can be based on a lot of things, right? It could be based on clinical findings, right? It could be based on if you have a laboratory result, like you have a HIV test that comes back positive. That's a laboratory result that may be included in surveillance. And then also we want to look at things like time, place, and then characteristics of the affected people. We do this too. Anytime someone calls up to the poison center who thinks that they have food poisoning, we start up the initial investigation and then report that out to the health department, and then they follow up because they want to find out, is there a particular restaurant that's contaminated, giving this to multiple people? We can look for different like little outbreaks of these things on the map, and we can try to find out where it's been localized to. But we have to know like who is exposed, what are the characteristics of people that might have been exposed, when were they there, where was it at? All that information is really important to obtain there. And so once we have sort of our objectives laid out, we have our methods here, then we need to figure out, who is going to be collecting, reporting, and then using the data. How are we going to be using that data to its, fullest capabilities here? And so typically you might see something like a pilot test being done, and this is sort of like an early test to see, okay, well, do these case definitions make sense? Are we actually getting the data we need to know there? And then they can expand it out, right? So then you can use it in a small test case, like in just within like one state or one county, and then if you want to do it nationwide, you can then expand out from there. But the field tests or pilot tests are mainly done to try to work out the kinks a little bit to better capture the data that you're actually looking for, right? And then every time you have one of these systems go online and they're working, you always have to go back and make sure that you're evaluating it, make sure it's still doing the thing that you want it to do. If it's not capturing the people you wanted to capture, then it has to, again, go back to the drawing board and figure what needs to be changed in order to make it work there. And so there's this idea of passive versus active surveillance. You're going to find that most surveillance that is going to be done on a passive basis there, because doing things actively obviously requires a lot more effort, time, money, etc. So if you're looking at cases where like a physician's office is reporting something out, like, or they get a case of Ebola, right, and they report that out, that's a form of passive surveillance because it's just relying on people to be reporting things out on their own without having any direct intervention by the investigators, right? It could be laboratories, could be hospitals. We say that they're required to report out a lot of different contagious or a lot of different disease states. Doesn't mean they always do it, right? So again, you're always working off the assumption that things are underreported rather than being truly reported, right? So for instance, with poisonings, for instance, you can look at the National Poisoning Data Center system. We report out every single year what the poisoning rates were in the country. We report out the types of poisonings that we found, but we always know the numbers aren't 100% correct because a lot of times we don't get the call. If you don't call the poison center, then it never gets reported out. So for instance, if I have someone who shows up to an ER who has like a Tylenol overdose, and it's a very simple case, and the ER physician feels comfortable handling it, then they may not call the poison center. And if they don't call, then we don't know about it, right? That's a form of passive surveillance, where again, you just know things are going to be underreported to some degree. Active surveillance, so, requires sort of like direct intervention. So people who are calling weekly or monthly, people who actually go to sites, make sure that data is being acquired, I should say, all of that. So very labor intensive, very costly. And so a lot of things, especially new things, typically start out as active surveillance, and then as things kind of die down or they kind of go back to normal, so to speak, then it goes into a phase of passive surveillance. Typically, that's normally what you'll end up seeing there. So again, based on whether you have an active or a passive surveillance system, you can find that the number of cases that are reported may be pretty different there, right? If you go hunting for things, you're more likely to find them than if you're relying on a sort of passive service there. So you can find sometimes actually changes in medical care can sometimes uncover issues with the surveillance system that you didn't really know about before, right? So for instance here, they had this hospital in Connecticut. They're reporting out on these cases of pharyngeal gonorrhea in young kid. And they're like, well, what's going on with this outbreak, right? Because the numbers were outside of what the normal cases were. They're all being reported out. So they said, well, something's going on here. Let's find out what it is. And so they found that it was localized. It was actually investigated by this kind of student faculty team here from Yale University. So they sent out this team to go investigate what was happening here. And they actually found that it started after the hospital was examining all throat cultures. So anyone coming in for like a strep test, for instance, they're also looking for gonorrhea there, right? So they're doing both tests at the same time, so they're finding more asymptomatic cases. So even though the numbers were outside of what the normal was, it looked like an outbreak, it actually was just because they were doing more surveillance. They actually were doing more tests. And so again, the more tests you do, more likely you are to find asymptomatic people. Okay. So there really was no problem. It's just they had higher numbers because of this one specific reason. Okay. So, as I mentioned, you're going to find most diseases, injuries, conditions, especially non-infectious ones, are going to be less likely reported, especially like on a nationwide sort of system there. And so we typically develop these surveillance systems on a problem-by-problem basis there, right? So again, why do we have the poison centers and the poisoning data monitoring thing? Is because poisonings were happening, right? It's a specific answer to a problem. And again, you're going to find that without significant support or funding from the governments, it can be pretty difficult to develop and to maintain. For instance, at the poison centers, we rely on state funding through the health department. And if we don't get any funding, there's been poison centers that have completely shut down, for instance, right? Again, I know I'm kind of making this about stuff I know about, but again, that's what I know the most about. So I'm going to keep talking about it. But as an example, there was a case, I think it was Louisiana, where they actually said, well, what's the point of having all this poison center? They're not even doing anything. They're just taking these phone calls. It doesn't really look like it's all that beneficial. And so they decided to go ahead and shut it down, cut all the funding out, and they closed it down. And then what they actually found was there's a huge increase in the surge of people going to ERs. Because the people that would have been calling the poison center saying, hey, my kid ate all these gummy vitamins, and normally we tell them, don't worry about it, stay at home, they were now showing up to the ER. So they actually found that the cost to the state was way greater than what they're actually using to fund the poison center. It was a money-saving endeavor. And so sure enough, the next year they opened back up, right? So it goes back to showing that, okay, well, cost goes into a lot of these things. Where does the money come from? Who's lobbying for that money? So it's important to have friends in high places because otherwise you may not get the funding you need to do these sort of surveillance systems. So again, it all comes back to, who's greasing the palms and all that. It's not the best system by any means, but it kind of is the system that we're dealing with here. Oh, someone asked, is there going to be calculations on the exam? No, you might have to do something like incidence density, where you're just adding up a couple of numbers, but it'll be very easy math because I understand you don't have like scratch paper and stuff, so I will take that into account. But it would be no more than simple addition of a couple of numbers. So as far as math goes, that's as far as you'd be able to get to. But interpretation of the numbers, obviously based off of last test, is going to be very important. So anywho, so going back to surveillance here, it's important that we establish sort of what our baseline is. And so we want to know kind of like what the normal pattern of disease is and know kind of what how does time of year affect this? How does things like different locations, how does that, how does reporting happen on those different type of things? So geography and time are going to be really important here. But by looking at the baseline, that we can see if something is out of normal, right? We can look to see, is this new rash of cases, is this considered to be a normal fluctuation, or is it actually an outbreak? Is it actually something that is abnormal here? And so what we can do is kind of look at the normal amount of data we see. And even though the numbers tend to be underreported, what you're going to find is even if you have limited data, as long as the trend is staying roughly the same, it's okay, right? Because you can still look at the trend and get a good idea of, okay, we don't have all the cases reported here, but we can at least see a fluctuation if it occurs. If we see a major uptick or downtick, it should clue us in that something is going on. We want to know about it, right? And again, looking at deviations from the usual pattern of data, that's how we define what an epidemic is, right? It's totally normal for people to get the flu in the winter months, but we want to see, is this particular number of people getting the flu out of normal, right? Is this out of whack? Do we need to go and see what's going on here? And so that's important, right? It's important in terms of surveillance. as I mentioned, long-term trends are very important here. So we want to see how things are changing from year to year, because even if we don't have all the numbers, seeing the trend is still important here. So for instance, here at CDC reporting about salmonellosis, right? Salmonellosis. They show a rise in the number of cases in the U.S. Okay, and so they're saying, okay, well, could the trend be explained by issues of disease detections? Are we finding more cases than we were before? Is it due to more reporting, or more people likely to report now, or is it due to both, right? And so when you're looking at this, when you either have an actual outbreak or you have a suspected one, if you report that out on the news, you say, hey, look, there's all these new cases of salmonella happening here. That sort of ticks off in the minds of providers to be more likely to look for it, right? So you think about, you always talk about developing your differential. You have that list of things in your mind that could be going on with the patient. Well, if you hear about it in the news, you're more likely to think about it, right? So for instance, if you had a patient you're dealing with that comes in for pneumonia, you may be more likely to think, well, hey, maybe I should get a COVID test for that patient, right? You would never have thought about that a year ago because it wasn't around, but now you think about it, it's higher up on your differential, you want to go ahead and check for it. Even though you diagnose a patient with pneumonia, they could also have that at the same time. And so that's what we want to look for. You look to see, is there some sort of change here? Did something come out in the news that's making more people look for it and then report it? Who can say, right? So if you're looking at, for instance, here's cases of salmonella reported in the U.S. is going from obviously the 50s up to about 2000. You can see that there were, the numbers were definitely increasing. So obviously there was a trend here. So something was going on, and then you see this big spike up, and then this is actually related to some contaminated milk in a particular state in Illinois actually getting out here. So again, you can look to see, okay, is this normal trend just the normal increasing, or do we actually get a big spike here? So this one's obviously pretty easy to determine just looking at that. So what they were concluding about this was that, yeah, there actually was a real increase in the number of cases that was happening here. So increasing number of outbreaks, and we saw the trend actually continue over an extended period of time, right? Looking for tiny blips on the radar may not be super useful, but if you can look over a long period and see, yeah, it's continuing to go up over that period of time, that's more powerful in terms of letting you think that, yeah, there's something going on here, right? So also, consider things like seasonal variation that occurs for a lot of different disease states, especially those that are infectious, right? You think about wintertime, think about people being inside, being close to one another, tend to see spikes in a lot of different infectious diseases we're going to see there. But also may depend on the route of spread, right? You're going to find that things like waterborne illnesses are more likely to spread during like the summertime, for instance. So we'll look at some cases of that. Usually the respiratory route are going to have a higher incidence in the winter times. Again, because people are inside, they're kind of breathing on each other a little bit more. So you're going to see more cases of influenza, right? And we'll look at a graph of that in just a moment. But you may see, for instance, things like diphtheria tend to peak up in early autumn because that's when kids are actually going back to school. So now they're being exposed to each other at a couple months off, and now they're being exposed to one another. Now they're getting diphtheria. Or how about things like insect-borne diseases, right? So for instance, like, diseases carried by mosquitoes, for instance, tend to be more likely reported in the summertime when they're more active and people are outside, more likely to be exposed to them, right? Or things like Lyme disease. Again, people are outside. If it's hot outside, people don't like to bundle up a whole lot, so they're going to be wearing fewer clothes, and so they're more likely to get exposed to things like ticks, for instance. So again, you can look for seasonal patterns. Some of it makes sense, some of it may not, depending on the disease state, but that can be important. You can even find some disease states happen, depending on the time of week it is, for instance. So if you're looking at like recreational drownings, they tend to happen more on the weekends. Well, why is that? Because more people are at home, they're out there swimming in their pools and whatnot. So maybe kids are more likely to, have drownings, unfortunately. So again, it just depends on what you're talking about. But here's an example here, the number of drownings. If you notice a very strong association here between Saturday and Sunday drownings versus throughout the rest of the week, because again, not to say that none of them happen during the week, but just saying that there's a lot more of them on the weekends, and it makes sense if you think about it. So when we're looking at epidemics or disease outbreaks or anything like that, we want to find out, is the frequency we're seeing now unusual, right? That's how we want to be able to define, or if we call something an outbreak, it needs to be because it's happening outside of the normal sort of variation we would see, right? because of the fact that a lot of times when you say the word epidemic, even though it may be the technically correct term, a lot of people tend to have a very gut sort of reaction to that, and they get very afraid of that. So outbreak is typically used for more localized things. So if it's something just in the state of Florida or like Orange County, you may call it an outbreak of hepatitis A or something, even though technically it's still an epidemic. But sometimes the messaging is important there. So, and again, it's only possible to know the level of disease if it's unusual, or only way to know if it's unusual is if we know what the usual rates are. And in order to know that, that's why we need to have reliable surveillance systems, right? So they need to show that what the normal level is, and then we need to see what we have now is outside of that. And so, for instance, here, like to determine when and where influenza and pneumonia outbreaks occur, the CDC basically looks at what the normal rates are, and then they have what they call an epidemic threshold, where basically they know what the normal trend should be, and then if they have a certain value that goes above that, or a certain rate that goes above that, they then consider that to be an epidemic, okay? Now, again, they lump pneumonias in with that because a lot of times you're going to see that when patients have like a death certificate signed, they may say that it's pneumonia, even though they never got tested for flu, but we probably know there's some association there, just based off the disease state and kind of what we know about the pathophysiology and all of that, right? But here's an example of looking at the solid line here is the actual proportion of deaths. Looking at the dashed line is that epidemic threshold, and then the solid blue line here is a seasonal baseline. So the blue is the baseline, so we kind of see what we'd normally expect over time. And again, you can see this from 94 up to 2000. And then you would see what the dashed blue line is like, okay, if it goes above this, then we consider that to be an epidemic or, again, an unusual occurrence of disease. And then the black line is the actual cases. And you can see here, yeah, 95, there's an outbreak. Here in 96, there's an outbreak. 97, looks like there's a lot of outbreaks happening here, right? So again, you should be adjusting with the seasonal baseline in it as well, based off of the data that you're actually collecting there. So again, a lot of outbreaks here, especially in 99. You can see there's a huge spike in the number of deaths associated with that. So, looking at sort of different why rates may change over time, maybe a new intervention came out, right? Maybe there is a new vaccine, for instance, that came out causing rates of disease to go down as a result of that, right? That's important. We want to see the rates of disease are going down, and the data should reflect that. If not, then probably we don't have a very good treatment, right? Or the vaccine is not very effective there. I guarantee you we're going to be looking at that, especially with COVID, because we want to know, okay, well, how long does the immunity last after this vaccine? Is it a durable response? We're expected to see where people get it and then they don't get COVID later on, maybe a year or two down the road, for instance. So looking at this, so if you're trying to determine whether a vaccine is effective or not, or if maybe it's failed, then you'd expect to see, a lack of changes in the case, for instance, or maybe you see like an increase in disease rates after an initial decrease. So it kind of goes down, but then peaks back up, showing that maybe people were protected for a period of time, but now they're not. Or maybe if you see an increase in disease in recently vaccinated groups, right? So, for instance, that inactivated polio vaccine we were talking about a few lectures ago, actually causing polio in those patients, right? That obviously was a failure of the vaccine because it caused the disease it meant to protect against. So, other cases we can look at this. So, and actually, this is a case where we had to change how we utilize a vaccine in order to account for what we were seeing in the data. So let's look at measles in the US here. We were able to detect that while the measles vaccine was effective early on, we saw that we actually lost efficacy as time went on. It actually led to change in the recommendations for how we actually vaccinate against measles, right? So what you found was in the 2006 recommendations, only 2 doses should be administered to young kids. Basically, they got a first dose when the kid was 12 to 15 months old, and they got a second one when they were 4 to 6 years old. Okay. What they're finding was, especially around the time that kids were like 18, 19, going off to college, they're seeing these big spikes in the number of outbreaks are occurring there of measles, right? And so that's why they now recommend a third dose, usually around the time you go to college, right? And a lot of colleges will have that as a requirement because we know that, okay, well, while it did protect those people for that period of time, it did start to die off. And so that's why we have to be able to adapt to the changes in data and adapt to the treatments to make sure that they're going to retain efficacy. So other ways we can look for changes in patterns of disease here. So for instance, we're looking at cases of syphilis that occurred. So both acquired I mean, you actually got the case of syphilis itself, or congenital syphilis, meaning it was actually given to the child of an infected mother, for instance, here, shows the changes of disease rate. So this is an example of 1980s in New York City, and they found these big spikes in acquired and congenital syphilis, and they're saying, what the heck is going on here? And so they actually found, when they were going back to it, it was around the time that the crack cocaine epidemic was beginning. So, and again, if you're not familiar with cocaine, crack cocaine itself is particularly addictive. And so you had a lot of these women in particular who were becoming addicted to the substance. And then again, when you're addicted to a substance like this, you will do a lot of things in order to get more access to that drug, right? And so, for instance, here they found that a lot of these women were doing things like trading sex for the drugs. Okay, so if you're having more high risk unprotected sex, that's where they were able to make the link there between the crack epidemic also to this new cases of syphilis. I'll show you a graph here in just a second. But also, because these women were having unprotected sex, they were getting pregnant. And then also, they probably didn't have good prenatal care. And so they were then passing that on to the kids as well, right? So again, it's interesting how something like an illicit substance leads to other types of disease. Or if you were to look at like, IV drug abuse and all the bloodborne conditions you can share there, like Hep C and HIV and all of that. So pretty interesting how things that seem disparate, seem totally unrelated, tend to be when you actually get down into it. So here are the cases here if you're looking at the rates of primary and secondary syphilis here, and then you're looking at the number of congenital syphilis. So the bars here are the actual congenital syphilis in the children being born here, and then you see the solid line here are the actual secondary and primary cases in the women. And obviously you can see here a big spike between 1986. The rates are pretty steady, and then all of a sudden it just skyrockets, right? So again, pretty interesting. Again, very unfortunate, but it's still an interesting thing to see the trends here. And unless you have a good investigation to look for this, to find out what's going on, we may still not know why we were able to see this big spike in the numbers, right? So, again, when you're investigating these epidemics, it's important to come up with a definition, right? So you have to be able to have a common definition to know whether an occurrence has actually happened here or not. And again, just because people think an epidemic is something that involves large numbers of people, it doesn't have to, right? So even just a single case of something can still be considered an epidemic. We have eliminated smallpox in the world, so even a single case of that would be considered an epidemic because our normal is 0 nowadays. So even one case would be considered to be pretty significant there. Or if we had something like poliomyelitis here in the Western Hemisphere, right? That would be very unusual, and so we'd want to know about that, right? And so, again, when you're saying that a disease is something that normally occurs and it's a regularly occurring thing at a pretty constant level there, that's going to be something that's considered to be endemic. And you might find different disease states are endemic in different parts of the world, for instance. And so, again, investigators, when they're looking at acute disease outbreaks, they want to know basically the measure of disease frequency. They call that the attack rate, right? So we want to know the normal sort of attack rates for a given population here. And so what it really is basically the proportion of exposed people that become ill, right? If you recall, we were talking before about how you can kind of slice up, the population of people that are exposed to a disease state, and then a smaller subset that were exposed actually get the disease, and then a smaller subset of that are the people that actually became symptomatic. Smaller than that, people that actually got really sick, and then smaller than that, people that actually died. So this is the number of people that were exposed that actually got the disease in question, right? And so attack rate is actually calculated here, the number of new cases of a disease divided by the number of people exposed in a particular outbreak. And again, usually by some constant multiplier, in this case here by 100. Now, again, I'm not going to have you calculate an attack rate specifically. I just want you to know what it is, so when you see it on the exam, you can respond to that, right? You can interpret it. Obviously, a higher attack rate means that more people it's more contagious, right? More people who have been exposed actually got the disease in question. So smaller attack rates means less infectious or less contagious. So again, when you're doing these investigations, the first step is always to establish your diagnosis, right? A lot of times you can find that epidemics can be solved, quote unquote, by just finding out that the number of cases you have there isn't really an outbreak at all, right? So in this case here, there's a health department in North Carolina. They got all these panicked calls from people who were saying that there's all this occurrence of smallpox in their community, right? And again, if the health department hears there's cases of smallpox, they should be pretty concerned, right? And there's a physician actually working working with the health department, and he discovered that the smallpox they were talking about was actually just chicken pox. It was actually people were being misunderstood on the phone. All they heard was pox, and then they leapt to conclusions that were not correct. So again, some of these things may seem silly, but again, they averted, a big concern, because if the news heard that there was smallpox, and all of a sudden that gets reported out, and then everyone who's sick all of a sudden thinks they have smallpox, they flood into the ERs, and it can snowball out of control there pretty quickly if things like this are not sort of nipped in the bud. So once you have your diagnosis there, yeah, absolutely. Fear is quite contagious, as it turns out, amongst people, especially nowadays with, people being so connected into, media all the time. Everyone's got their phone in their pocket. Everyone has access to that stuff, and things can spread quite quickly. But again, it's probably another college class to talk about that, not my course. But so first off, we're establishing our diagnosis, and then we're looking at the actual case definition. So how do you determine whether you're going to count someone in this disease state that you're investigating, right? So there's usually a list of specific criteria used to determine whether or not the person has a disease of concern, right? Again, this is not the same as a clinical diagnosis, because in some cases it may be very early on. You don't even have you don't even know what the disease state is. You may just have a disease state where these people all of a sudden are having, nausea, vomiting, diarrhea, and elevated white count and fever, right? We don't know what the disease state is. We just know that these people have share all these common characteristics, and that's what we're going to call our case definition, right? And so again, a consistent criteria that allows us to proceed before we get a definitive diagnosis, right? So that's why, again, we were thinking about things like someone calls the health department or the poison center saying, hey, I just ate at this restaurant. All of a sudden now I'm vomiting my brains out and I can't get off the toilet because I'm having such bad diarrhea. You may not know what the disease state is, but then you can determine what a case definition is to be able to then do further investigations, okay? So again, this is important if the disease is unknown. So no case definition will be perfect, and these things are mutable. They should change as needed once you kind of find out, more information about during the investigation here, right? There's always going to be some false positives. So again, just because you have nausea, vomiting, diarrhea doesn't mean that you have food poisoning, right? Just because you ate at a restaurant that is being investigated for food poisoning doesn't mean that you got food poisoning because you have diarrhea, right? So again, there can be false positives there that occur. Again, individuals without the disease wrongly included in the group considered to have the disease, right? So there's that, but there's also can be some false negatives, or people that should have been included but have not, right? We thought that they were disease-free at first, but that was a wrong conclusion there. And so again, by using a case definition, that allows the epidemiologist to make comparisons amongst, different outbreak investigations. They can look at how their case definition compares maybe to others, see whether they're similar or not, and that can help out the investigation as well. So next we have to characterize it by time, place, and person. So this is really important too. We have to figure out the who's, the what's, the whys, and all of that during this investigation. And so, again, figure out, is there a geographic link here? Is there a time link there? And who was actually affected? Is it just children that are affected? Is it just elderly? All of that can be useful information there. And again, it's unwise to start the data collection unless we have a case definition, because then you're going to be collecting too much data. You're getting too many people involved with that who may not actually have anything to do with it. And so again, this helps us to classify persons either affected or unaffected, and that again can help to clear out some of those false positives and negatives, hopefully. So looking at time specifically, we can find that when you're plotting the outbreak or the number of occurrences you're having based on time, you can get what we call an epidemic time curve. And so that can be very useful to look at. On the x-axis, the number of new cases, and on the y-axis, x is going to be time. On the y-axis, you're going to be seeing the actual number of cases occurring there. And you can see, okay, does it, how does that curve change? Is it all starting off with a very small number at first and then it spikes up, or does it spike up at first and then dip down and then it pops back up again? All of that can kind of give you different information about the epidemic, how it's spreading, things like that. So we'll look at some examples of that here going forward. So, some of the questions that can be answered by looking at the time frame for these things here include, well, what was the type of exposure, right? Was it a single source of exposure? Like maybe there's contaminated water, for instance, that was the common source. Like maybe go to camp and there's contaminated water, so everyone's exposed to that same water where the people got sick? Or was the spread maybe person to person, right? Maybe one person gets exposed and then they pass it off to someone else, right? Those curves will look very different based on how it's being spread there. And then what was the probable route of spread? Was it more respiratory? Was it fecal oral? Could it be related to, animal vectors, for instance? That will help us to determine when looking at time, which ones are likely there. When were the affected people exposed? Not everything happens immediately. Some things take hours or days in order to manifest. So it's good to be able to link that back towards when were they exposed versus when did they get sick, because that can help us to clue in on things like incubation periods, for instance. And so another thing we'll talk about is the idea of primary cases, or persons who were basically initially affected by that common source, and then secondary cases too, where they, you got exposed to a contaminated water source and then you spread that off to someone else in your household. That would be considered to be a secondary case there. So sometimes you'll see that kind of propagation that occurs between the first primary cases to secondary ones. When looking at like common source exposures, again, a lot of those people will come into contact with the same source, whether it be like food or water or things like that. The curve is going to be very sudden onset, a big peak, and then a rapid decline as they are no longer exposed to that. So, for instance, if you were to see, contaminated food at a restaurant, everyone would have been exposed at roughly the same time, and then it just dips back down as those people either die or recover, right? If there is more of a person-to-person spread, then that's going to be more of a prolonged sort of irregular pattern as they are exposing other people, and that's called a propagated outbreak, right? So it's kind of the difference between sort of a common single source versus more of a propagated outbreak. And sometimes you can actually have both together, especially if the common source can lead to person-to-person spread. You can see a bit of a mix there between the curves. Now, place is also quite important as well, because we're going to be defining the location of cases, right? Was it a particular restaurant? Was it a particular county? All of that. And sometimes actually maps can be useful. If you're actually plot out on the map where all the cases actually occurred, that can help you kind of zero in on where it was. Was it at school? Was it where people are living? Things like that can help you out in determining, okay, well, what was the common source of exposure here? What was the location? And so probably one of the most famous ones of these were done back in the 1800s in London by John Snow, not the one you're thinking of up at the wall. But basically they were looking at cases of cholera that were occurring here in London. And so he wanted to find out, well, what was the link between all of these different cholera cases? And when he plotted out on the map, he found that there was definitely a clustering of cases around this one particular water pump that happened to be infected. And once they got rid of that, they removed the handle and no one can go to that water pump anymore. All of a sudden the cases dip down. Here's what that looks like. If you could imagine looking at this and plotting out all the little individual numbers here, notice here it's pretty sparse as you're farther out, and then as you zero in closer and closer to the actual water pump, a lot of the cases right there, right? These people out here are probably going to a different water pump versus the ones that were all getting from the same source, right? Then you get rid of the source, and then all of a sudden the numbers started going down. But unless you actually do that investigation and actually plot it out on the map, you may not know that and then never come up with what the common source of exposure was. So again, spot maps can be helpful because they show the numerator or the number of cases, but they don't really tell you anything about the total number of people at risk for having been contaminated, right? So the denominator in that case there. And so, when we're looking at incidence rates by location, we can do this in a couple of different ways. So for things like, if we're looking at like hospital wards, we want to look at, for instance, certain types of infections that have occurred, like if you're looking at like pseudomonal infections by ward. If you wanted to look at, by classroom or even like, by certain portions of a city, incidence rates can be very useful for that. Because again, you can define, okay, well, here's the number of people in this hospital ward who are at risk, and then what are the numbers there. So again, location important. So another thing you may find too can be really challenging is when you hear about clusters, right? Because again, as humans, we like to look for trends in data. We like to look for patterns that may not necessarily be there. That's kind of part of our natural survival instincts and things like that. So oftentimes you may hear these cases of clusters popping up and you're like, wow, there must be some link here. There must be, they all, these kids all had cancer that developed and they all went to the same school. Maybe there's something in the school causing cancer, for instance, here. One of the challenges that we, the epidemiologists will handle is trying to figure out, well, is this occurring just due to random chance? Is it not truly an epidemic, or is it something actually happening there, right? And so that's one of the things we're trying to find is that, yeah, would this have been likely to happen just by chance alone, or is there actually a real difference here? And again, that's where things like statistical tests can really help them out with that. And that helps them to determine whether these clusters are real or not, but it still can be challenging. So, for instance, here, if you're looking at like a cancer cluster that's occurring, we want to know whether or not that there might be an environmental problem, right? So if a group of kids all got this, a type of cancer and they all went to the same school, then you want to find out, well, is there something there causing it? And so, different characteristics can clue you in on that. So for instance, is it a lot of various types of cancers? Are you seeing like one person had lung cancer versus colon cancer versus prostate? Then it's probably not related to the same exposure, right? Because again, environmental exposure tend to cause the same type of cancer here. And then again, you want to know what the normal rates of cancer would be in that particular group anyway, right? To see whether what you're seeing is out of the normal or not. And if it is, if you're seeing the same type of cancer, for instance, and you're seeing it outside of the normal rates, then that's where you want to do further investigations. Okay. And then looking at the person, also again important to know good characteristics to look at include things like age, sex, ethnicity, even religion can matter here, immunization status. All these are types of things that investigators will look at to see, is there sort of a common link here, right? Did all the people all have the same religion? And so maybe they were going all to the same church or having the same religious practice, for instance. Are they all people that were immunized with the same vaccine, for instance? These are all things that can be important to include when you're doing these investigations here, because they all may have make a difference there. So once we have all the information collected, we have our case definition, we know who we want to include in that, we know what kind of information we want to collect about those people. Next, we have to develop a hypothesis, right? So trying to come up with, well, what do we think is going on here? What do we think is the source? What do we think about the type of spread we're seeing here? Who are the people that are being affected? They have to come up to say, okay, well, what's our hypothesis? And then they test it to see whether it's true or not. And so again, they're looking at the source of infection, especially if it's a person, or if they're looking at a particular source there, finding out if it was in a particular type of community or not. They look at the type of spread to see whether it is from a single source or if it's more propagated. And then, as I mentioned, a common source pattern there. You'll find it. Okay, all these people were at the same location at the same time. It makes sense that, yeah, that's where the actual infection occurred, right? For instance. Again, when you see propagated patterns here, it's typically going to be person-to-person spread, and that's going to be happening over a longer period of time because, again, it takes time for that person to spread to someone else, it incubates, and then they get the disease, and maybe they pass it on to someone else. But again, there can be mixed patterns there where they have a common source exposure, but it's still infectious, and they can then spread it over to someone else, for instance. So again, you'll find many types of infections will have more than one type of spread, just like I was talking about there. So for instance, like Shigella is one you can see with contaminated water, but then can be spread from person to person. HIV is one in particular where you can actually have various types of spread. For instance, you can have, for instance, IV drug use. Using contaminated needles is one means of spread, but also sexual contact, right? So just because someone has HIV, you don't want to assume, oh, they must be an IV drug user, right? Because that's not the only way that it spreads, okay? But again, until we found that out, and that by actually doing investigations, we didn't know. We didn't know how this stuff was actually spread from person to person. And again, the mode of transmission may be respiratory, could be fecal oral, could be skin to skin, could be all sorts of things there. So, and again, it could be a mix depending on the type of disease you're talking about. So looking at testing hypothesis, things like laboratory studies can be very helpful here, right? So for instance, if you think it's something it's infectious in nature, you want to look at things like cultures, right? Look at cultures not only from the patients, but also go back to the source. Was it a particular type of food or water that can be tested? You can look at the stool. You can look for things like ova and parasites and things like that. Looking at serum antibody tests, right? That's important as we're dealing with COVID right now to see whether someone's having an acute infection versus maybe they're more convalescent, meaning they've actually recovered and now they just have antibodies to the disease without actually having the disease itself, okay? Or we could do things like testing for toxins and drugs and whatnot. We think about like lead exposures. You can actually go into the home and look for lead. You can check water sources for things like that, drugs, all kinds of things. Actually, an interesting one with drugs just thought about was with certain samples of cocaine. There's actually a contaminant that's in a lot of cocaine samples we find here in the U.S. Called levamisole. And levamisole is actually an antihelminthic product. We don't know really why it's contaminated all these sources of cocaine. We just know by the time the cocaine gets here into the U.S., it's contaminated with this levamisole, right? And so why is that clinically important? Well, because levamisole can actually cause aplastic anemia. And so the way we found this out was you had these people who were coming in who were reported cocaine users, or maybe we tested the urine and saw they were positive for cocaine, and they came in and their white counts are just completely off. Like they're completely agranulocytosis, aplastic anemia, all these things were happening here, and some of them were dying from infections, and they were just like, well, what is going on here? What is the common link here? And so they're able to look to see, okay, what are the common characteristics between these patients here? Found, okay, cocaine use was, the common characteristic. Well, what was it about that cocaine? Because normally cocaine doesn't do that. So they're able to get samples, analyze it, and then find the levamisole, right? So again, these are how these epidemics are sort of investigated. Even with this illicit substances or infectious disease, kind of go through the same process here of testing their hypotheses, right? So another good way to test a hypothesis is to do a case control study, right? We know these are easy to do. They're relatively cheap because they're retrospective cases here. But one thing we can do is to, especially with like a foodborne outbreak of disease here, it's very handy to look at cases or people who are including in our case definition who meet the criteria, and then we compare them to a sample of controls, right? And so we look for things like common risk factors in the past that they may have been more likely to be exposed to in the case here. So for instance, if you have a lot of people that all ate at a restaurant, right? So they all ate at the same restaurant. Some of them got sick, some of them didn't. And then you take the cases that ate there, and then you then compare them to controls. You can look back to see like, well, what were the common things that they were eating or not eating? If you saw all of a sudden that all the people that got sick were eating the sushi, but a lot of the people that did not get sick didn't have the sushi, well, then you can make some inferences about, well, perhaps the sushi was the source of exposure, right? Just using that as an example. I love sushi. I don't mean to denigrate it at all, but raw fish it carries some risk with it, right? Especially if you go like at gas station sushi. I would never do that, right? With the fresh stuff. Regardless, again, case control studies are really handy for that because you can do odds ratios and actually determine, is there a statistically significant difference here in exposure to certain risk factors that the cases had versus the controls did not, right? And then once we have this outbreak actually occurring here, we got to say, well, we got to do something about this, right? We need to do something in order to control the spread of this to help treat patients better. And so before we even know necessarily what the disease is, there may be means of control measures that can be implemented before you have the full story, right? So for instance, if you think it could be a food related exposure, well, then get rid of that food, for instance, or like with the example of the water pump, like getting rid of the handle so people can't go back to that water pump to get water was a control measure, okay? And so the control measures should be done as a way to where they can't also interfere with the investigation of the outbreak. So you got to make sure that that's not going to be sort of a confounder there. But there's kind of 4 types of interventions you may see done most commonly during an outbreak. Sanitation's a big one. So especially if we are able to modify the environment so that way people cannot spread disease any further. So if we can do things like removing pathogenic sources of infection, so like the water or the food, if we can remove the human source of infection so that way they can spread it. So for instance, when we all went on lockdown during March, that was a means of controlling the spread of COVID. Or if we can prevent contact with the source by removing susceptible people from the environment, it's another way to do it too. So for instance, we know people who are immunocompromised are more likely to die from COVID, so try to sequester them away or have other control measures to keep them from getting it potentially. Sometimes we can do prophylaxis, right? So putting a barrier to the infection with people who happen to be susceptible here. So you may find, for instance, like, there's a recommendation for entire populations in terms of trying to prevent disease prophylactically, especially even starting with infancy, right? So this is where we can do things like utilizing vaccines to prevent a disease from occurring in the first place, right? In some cases, we may want to do short-term protection. So if you're going to a country or a location where a disease is endemic there that the person's not normally exposed to, you may start prophylactic medications to prevent that. So for instance, if you're going to go to places where malaria is endemic, you may start taking anti-malarial drugs to protect yourself, right? And again, you're going to find the diagnosis and treatment of the people who are infected, so that way the infected people don't then spread it to others, right? So you want to treat those that have the disease already, prevent them from spreading further. And then if we can do things like controlling disease vectors like mosquito nets and things like that, that can be also helpful. So one of the important aspects here, again, of controlling spread of disease is going to be the written and oral communication, right? So making sure that the information gets out to the appropriate people, to health professionals, to the public, to make sure it's communicated clearly and effectively what they should be doing, what's actually happening there. This again can be challenging in terms of like the messaging, especially if there's like conflicting messaging and things like that. But you know, things like the CDC coming out and saying, hey, this is a disease we're seeing here, here's how to prevent the spread, things like that can be helpful to disseminate that out. How do they disseminate it? You know, are they getting it out on you know, social media platforms? Is it just going out to the newspapers? I mean, who reads a newspaper anymore? Things like that. So communication is super important for these. That helps to prevent spread. Keep in mind though, also communication can be a challenge too, because if people are thinking about the disease state, they're more likely to think they have it just because you get the sniffles. Or I've probably had no less than a dozen instances this year where I've been like, I don't know if I can smell anymore. Can I smell anything? Maybe I have COVID. I don't, obviously, but you know, it's one of those things where you just, again, it's on your mind. You're more likely to think about it, and then people then act on that information. So, and then follow-up surveillance is going to be really important here too. So again, any intervention that you put in place, you got to see how effective it was. And so this is where that follow-up is going to be so important here. So again, surveillance, secondary surveillance is very important here in terms of active initially. So you want to do active surveillance at first to see how the interventions are working. And then as things die down or it gets back to a sort of a baseline, then you can go more into a passive surveillance sort of methodology. So that's it for this section. I think I only have about a couple minutes left here, so I don't necessarily want to drag it on or start something new up, because I don't think I have enough time to talk about the next thing. Yeah, definitely. The next thing's going to be a bit of a big topic, so I'm going to leave that till next time. Do you guys have any questions before I let you go? Anything I can answer for you? I don't see anything on the sticky board. Well, if not, I think it was a good set of topics there. If you have any questions, though, either feel free to shoot me an email, or I'll see you guys next time. I don't think if I see you all at all this week, actually. If we have any more farm or not. Yeah, thanks. You guys have a great day, and I will see you all next time. The average flight speed of an unladen swallow. Is it African or European? Well, Brian, you can go into the abyss below, I suppose. All right. Thank you all. I will see you next time.